यही है वेलकम स्लाइड ना अमित?
सर यस सर।
बस ये सामने रख के आई विल बी स्पीकिंग वेलकमिंग एवरीबॉडी वंस एवरीबॉडी जॉइंस। 47 हुआ है अभी। Nikita has asked, mic icon is not visible. Sai, you'll have to answer it.
Sai sir, do we start?
नाही 58 झाले.
Okay.
85 आहे. એટલે आज घेतोय ना सगळ्यांना. He is taking people in.
We'll wait for 2 minutes and start, doctor.
Yeah, 59 हो गया. all the participants are requested to wait because we are adding more people. Once we start, I'll give the welcome speech to everybody, and then we start the quiz.
Doctor, should we start?
69. Any more to be added, Sai?
I think so. Once we start, I think we may get, Doctor.
Okay, okay. So this will be live on YouTube also, or no? At the moment, only on the Zoom.
I'm going to push it to YouTube now.
Okay.
Should I start?
Yeah.
Just a moment. Doctor, we are live. We can go ahead.
Yeah. Very good morning to all the ophthalmic fraternity, the PGs, the fellows, and the ophthalmologists who have joined Pan India. This time we have a Pan India quiz. There will be no separate participants and audience. Yeah, everybody has to compete Pan India. So this is the second round of quiz that we are having. Attractive prizes are there. There are 4 big prizes which you are going to reveal. I'll keep it as a secret. What is the amount? because more thing is we want you to compete. And definitely, if you are good, you will be claiming the prizes. Today's we have two grandmasters, quiz masters with us, Dr. Sumit Lahane and Dr. Rohit Modi. So they'll be explaining you all the rules further about the quiz. And over to you, and we wish you all the best, everybody. Over to you, Sumit and Rohit.
Thank you so much, sir. So first, I would like to thank MOS, Dignesh as well as sir, Rajesh Joshi sir, Dr. Ragini ma'am, Quresh Maskati sir, and this is basically a brainchild of Quresh Maskati sir and Dignesh Taswala sir, who wanted a quiz on the monthly basis, so that it's basically a platform for everyone, all the PGs, general ophthalm, subspecialist, and it becomes a good competitive session on Sunday. It takes only 1 to 1.5 hours of yours, but prepares you for a competitive thing. It clears you conceptually, because what happens after our post graduation, we never go for the MCQs, and a lot of things which are unknown, which are not studied, are never studied. So this kind of quiz, which basically in a competitive manner gives you a lot of information and teaches you a lot. So it's basically a part and parcel of CMEs that MOS conducts. So saying all this, I would be showing certain rules. I need to, can I share my screen, please?
Vishnu, you have to stop share.
Yeah, thank you so much. So this is just to introduce you with the rules of quiz. So there are total 40 questions. 20 of each will be asked by me and Dr. Rohit. One correct option for each. There are no negative marks. 30 seconds for each questions to be answered. You need two devices, one for Zoom and other to play, or you can have only one device where you can minimize the Zoom and play on the other device. Basically, it's a gaming platform on which you need to mark the answers, and you'll get 30 seconds to mark those answers. Again, this is a pan-India quiz. Everyone can play. But to claim the winning prize, we request you to be MOS members, and we will be calling you for the same once the winners are declared. And for all the reasons, the quiz master's decision is final. Now, I would like to introduce my colleague, my friend, Dr. Rohit Modi here. Dr. Rohit Modi is retina and UVI specialist. He did his fellowship from LV Prasad Eye Hospital, and he is practicing in Mumbai. He was also secretary of Bombay Ophthalmic Association. He is a very active member of YOSI. He is a very active member of scientific committee. And the most important thing is he is always available for everything that you ask for. Let it be a lecture for a postgraduate, let it for a hackathon with IITians, let it be a scientific program. Dr. Rohit is always available with all his enthusiasm and energy. So it's always nice to have Dr. Rohit here. And he is my colleague and a quiz master for today, and he will be starting with his first 10 questions. So I hope everyone has it's cleared about that we will be live here on the Zoom. We'll be asking questions, but you will not be able to answer questions on the Zoom. To answer questions, you need to go on the other link that has been provided to you in the chat box or on your WhatsApp or on your email. So on the Zoom, you can listen to the question and the answers, but the answering and the playing will be through the another platform. Over to you, Dr. Rohit.
Thanks, Dr. Sumit. So I will be starting with the first 10 questions. Uh, yeah. So is my slide visible?
Yes,
Yeah,
very
yeah,
good.
Yeah. Sure. So I'll just start with my questions. The first question is, which of the following is the most appropriate indication for periocular corticosteroid injection? Is it unilateral intermediate uveitis associated with macular edema, unilateral toxoplasmosis chorioretinitis affecting the macula, unilateral acute retinal necrosis, or unilateral Wegener's granulomatosis necrotizing scleritis? Your timer starts.
Doctor, the timer starts when you start opening the options, and for 30 seconds.
Okay.
Now the time is up.
Thank you. So the answer is unilateral intermediate uveitis associated with macular edema. So deposteroids are traditionally used for unilateral inflammatory conditions which are affecting the posterior segment, and it is usually avoided in patients who have infectious uveitis. And for scleritis, it is not commonly used. Coming on to the next question, which is the following is the most common cause of severe visual loss in patients with punctate inner choroiditis? Retinal detachment, macular edema, choroidal hemorrhage, or choroidal neovascularization? Your time is up. The answer is choroidal neovascularization. So, when we look at punctate inner choroiditis, usually macular edema may be present, but retinal detachment and choroidal hemorrhage are uncommon. Moving on to the next question. Which of the following is the most common side effect of mycophenolate mofetil? Gastrointestinal upset, renal insufficiency, hirsutism, or headache? So the answer is gastrointestinal upset. In a study of 84 patients, around 20 to 30% patients had gastrointestinal upset on usage of this following drug. That's why it's the most common side effect with usage of mycophenolate mofetil. Which is the most successful procedure for congenital glaucoma? I'm so sorry. In which of the following the trabeculotomy will be most successful? Neovascular glaucoma, history of significant recent onset trauma, history of significant recent ocular trauma, and previous clear corneal extraction. So the time is up, Sai.
Yes, doctor.
So the answer is previous clear corneal extraction. So in a patient with trauma or a patient with neovascular glaucoma, the chances of failure of trabeculotomy is very high. Whereas a patient who has undergone clear corneal cataract extraction, the conjunctiva is not damaged, and the results of trabeculotomy are the best in these kind of patients. Which of the following clinical finding is suggestive of the diagnosis of pigment dispersion syndrome? Iris Bombay, reduced pigmentation in the trabecular meshwork, mid-peripheral iris transillumination defects, or phacodonosis? Well, mid-peripheral iris transillumination effect is very characteristic of pigment dispersion syndrome. It is because of the iridozonular contacts that the pigments are dispersed, which can get deposited on the corneal endothelium and can be seen as Crooked symbol also. Which of the following findings is a risk factor for corticosteroid-induced glaucoma? hyperopia, family history of POAG, systemic hypertension, anatomically narrow anterior chamber angle. Yeah. Is the time over, Sai?
Yes, doctor.
Yeah.
Somebody
Family
is
history.
answering in the chat box to tell them not to do it. 6B dala hai somebody.
Family
Please don't
history.
answer on the chat box.
Yeah, I request the same. Please do not answer on the chat box. Family history of POAG is an important factor in considering steroid-induced glaucoma. A mutation in which gene is associated with juvenile open-angle glaucoma in 88 to 33% of the pedigrees. The options are fibrillin, optineurin, rhodopsin, or TIGR/myocilin. Is the timer up, Sai?
Yeah.
So the answer is PIGR myocilin. A lot of progress has been made in associating the genetic predisposition for glaucoma patients, and this gene was highly associated with juvenile open angle glaucoma. Well, a patient has hyperopia and a shallow anterior chamber is at minimal risk for which of the following complications? Iris prolapse, rhegmatogenous retinal detachment, choroidal effusion, or intraocular lens dislocation.
Again, somebody is answering on the panel.
Please follow the rules. Those who will be answering over there will be disqualified. Is the timer up, Sai?
Yeah, now.
Yes.
Yeah. So rhegmatogenous retinal detachment is commonly seen with patients of myopia or those who have peripheral retinal degeneration such as lattice degeneration. Iris prolapse or choroidal effusion is more commonly associated with hyperopia. Well, following an uncomplicated phacoemulsification, the patient's intraocular pressure was 35 millimeters of mercury. Which ocular hypotensive medication is the best choice to control the elevated pressure in the immediate post-operative period? Whether it is mannitol or pilocarpine or apracolinidine or latanoprost. The answer is apracolinidine. Well, apracolinidine starts acting in the immediate post-op period. Latanoprost can increase ocular inflammation and increase the risk of CME in the post-op period. And mannitol has its own systemic side effects. That's why the number one drug of choice may be apracolinidine in the post-op period. The 10th question. Now, selecting an intraocular lens for a child undergoing cataract surgery, what should we take into account? That typically what factor that typically occurs with growth, whether it is a hyperopic shift or a myopic shift or increase sulcus diameter or increase capsular bag diameter. Is the time up, Sai?
Yeah.
Yeah. The answer is myopic shift. Because of the increasing axial length, there is a variable degree of myopic shift in the children. That's why this factor needs to be considered while calculating the intraocular lens power. Thank you. The next set of 10 questions will be asked by my friend, Dr. Sumit.
Thank you, Rohit. Those are really nice questions. And I will start with question number 11. So, based on the appearance of the corneal infiltrate, you can see a figure here. Which laboratory test will be least helpful in aiding the diagnosis? Please read it properly. Least helpful. See the picture very properly. It has clue in its own. Culture on the suborder agar, calcoflower white stain, Lowenstein-Jensen agar, or GM stain. So, which is least helpful? Like what you will not do in this case when you want to send a corneal scraping. 5 seconds left now. And time is up. I go ahead with the answer, and I can see, yeah, most of you, 75% answered have correct. It's Lowenstein-Jensen agar. But if you see very properly in this, you see the pigmentation in the center, feathery margins, very classical of fungal ulcer. And Lowenstein-Jensen agar basically we use for the mycobacteria and not for your fungal. So suborder agar, calcoflower stain, GM stain, for that say gram stain, KOH mount, all are used for fungal, but you will not use the Lowenstein-Jensen agar. If you've been asked that what one thing you want to do out of this, you will go ahead with the GM stain or the KOH if at all it is available, because culture is going to take time in case of fungal. Let's move to the next question now. Which of the following condition is not associated with the rheumatoid arthritis? It is not associated with the rheumatoid arthritis. And your options are limbal follicles, peripheral ulcerative keratitis, necrotizing scleritis, paracentral keratolysis. So rheumatoid arthritis, a disease most commonly seen adult individuals, and they present with lot of ocular symptoms, and if not treated properly, many times they are debilitated with their joint deformities also. Ocularly, what you don't see in these cases. So your time is up. And again, most of you answered very correctly. It's limbal follicles which you will not see. PUK, necrotizing scleritis, and paracentral keratolysis are very common associations. Dry eyes and the scleritis are another associations of the rheumatoid arthritis, which we must know. And once you see such a case, many times they do present to the ophthalmologist prior to they present to a rheumatologist. You have an unexplained dry eye in a 45-year-old female, and you must do the rheumatoid arthritis factor and see that patient should be started on the early immunomodulators and disease modifying agents. So you do play as an ophthalmologist very important role in the diagnosis and the management of the rheumatoid arthritis. Let's move to the question number 13. Which of the following is associated with glaucoma? Options are Axenfeld syndrome, Peters anomaly, both of them, neither of them. And your time has already started. So basically what we are talking here, both are congenital anomalies. We want to know, are they associated with the glaucoma too? One of them, both of them, or neither of them? 5 seconds left here. And your time is up. Poll is locked again. Yeah, correct. 91% of you have answered very correctly. Both of it, Peters anomaly 2, which presents with the anterior segment anomaly, where the cornea and the iris and the lens are adherent to each other, very much likely to cause glaucoma. So both these diseases are associated with the glaucoma. This is just a description of Axenfeld and Rigas anomaly. Let's move ahead. Question number 14. All of the following are associated with the conjunctival cicatrization except atopic keratoconjunctivitis, ocular cicatricial pemphigoid, Stevens-Johnson syndrome, superior limbic keratoconjunctivitis. So conjunctival cicatrization, many times you see a patient again with the dry eyes and having a lot of surface inflammation and they need a long-term management. They keep coming to you, but the treatment does not solve the issue in a day. And the poll is locked. Yeah, correct. So answer everyone given here is superior limbic keratoconjunctivitis is very correct answer. So I would just like to add certain things in the diagnosis. The one thing which was one of the most common cause of cicatrization, trachoma, which is not seen much of the days, you do see still in the older patients. Ocular cicatricial pemphigoid, Stevens-Johnson syndrome. Basically, they mimic each other in a chronic phases. And if you want to differentiate, if at all, OCP and SJS, sometimes you might need a conjunctival biopsy to see that you are dealing with the OCP, because Stevens-Johnson syndrome is one-time inflammation that happens due to the drug reaction. But OCP is a progressive reaction which keeps happening, and no matter whatever you do, patient has a miserable ocular surface. Moving on to the next question. All are true regarding Goldenhar syndrome, except your options are iris coloboma is present, upper eyelid coloboma is present, preauricular skin tags may be present, and it can have an autosomal dominant inheritance. So you need to mark what is wrong, what is not there in Goldenhar syndrome or least common in the Goldenhar syndrome, and the rest are very much present. So is it autosomal dominant? Are there colobomas, iris or eyelid? And are there preauricular skin tags? Again, a commonly seen anomaly. And yeah, there is a tie between A and D, but answer A is correct. Iris colobomas may be present. This is very less likely feature of a Goldenhar syndrome, and it's autosomal dominant with upper eyelid colobomas and periocular skin tags also. Many of the times, Goldenhar do present as a sporadic nature way also instead of autosomal dominant. So all three options B, C, D are correct. A is wrong. Which of the following statement, where you can see a figure, a clinical picture here, and it's correct in the condition. So Thymus pubis is normal commensal of adult mammalian gland. Demodex follicularum is transmitted by sexual contact. Physostigmine act as a respiratory poison to the Thymus pubis. And Demodex follicularum is responsible for cholerae along the base of the eyelashes. Sorry for the long options. But it's a common disease that all of us see. And I see everyone has marked as D. Okay. So the statement correct we wanted here, correct answer is C. Physostigmine act as a respiratory poison, and it can be used ocular ointment, but it basically has a lot of ocular toxicity. So we don't use it directly, but it is a respiratory poison to this mite. Demodex, on the other hand, is a commensal of adult mammalian gland. The option A and B are basically other way around, and that's how they have been written. Thymus pubis it's something that is transmitted by the sexual contact, and the cholerae that you see generally in OPD are caused by the staphylococcus and not by the demodex. So option C is correct here. Let's move on to the next question. Which is correct regarding the lesion pictured in figure? And the options are: histopathology shows fibrovascular ingrowth just beneath the Bowman's layer. A pigmented iron line, a Ferry's line, is found at the leading corneal edge of the lesion. Prolonged actinic exposure is a risk factor. Recurrence after the treatment is rare. So which is correct regarding the disease that you are seeing here? This is again a very common condition. And your time is up. I hope everyone gets it correct. And not everyone has got it correct. So 46% of you have marked answer as B. But sorry, a pigmented iron line, a Stocker's line is found at the leading corneal edge of the lesion and not the Ferry's line. Option C is correct here. A prolonged actinic exposure is a risk factor. What are we talking here about? Is a pterygium. Recurrence is not rare after treatment. It is basically varied percentage given in the literature, which starts from 10 to almost 42%. And histopathology again is not correct. Let's move on to the 18th question. We are completing almost first half of the MCQ quiz today. So which one of the following statement regarding the disease shown in the picture is true? It is isolated non-hereditary disease. The corneal findings can be used to monitor therapy. It is caused by defect in the kidneys, and the corneal findings are pathognomonic for the patient's disease. So, clinical picture, generally a systemic reference that comes to an ophthalmologist to see particular lesion in the cornea on slit lamp. The poll is locked, and here we get the answers now. So the correct answer is the corneal finding can be used to monitor therapy. You know, it's basically related to the liver metabolism. It's Wilson's disease, which causes this Kaiser-Fisher ring. Again, a Kaiser-Fisher-like ring can be seen in the biliary cirrhosis, chronic hepatitis, or intrahepatic cholestasis, which will not be classically like this, but again, it will be little thin, and the deposition will be on the Descemet membrane. Why it is important? Because it is one of the triad of the Wilson disease. For the diagnosis, it is important. So though it is not pathognomonic, but it is important as a factor of a triad, and it is important to monitor therapy. So if you see cases where the bilirubin levels and the liver function test comes down to normal, again this copper deposition rings which are there in the Descemet membrane, they reduce in the size. So you can clinically actually mark the size of the Descemet, this case of Fisher ring that you see, to help the physician. Moving on to the next question. Which is the most common corneal dystrophy among the options given? Option A, lattice stromal dystrophy. Option B, macular stromal dystrophy. Option C, granular stromal dystrophy. And option D, Meesmann's dystrophy. So you know there are various kinds of dystrophy: epithelial, subepithelial, stromal, endothelial. Stromal are most common, and you want to find one here which is most common among all the stromal dystrophy. That ends your time. And let's see. Yeah, the 48% of you have answered correctly. Lattice stromal dystrophy is most common dystrophy. And Meesmann was the odd man out here with basically epithelial dystrophy and not the stromal. Moving on to the dystrophy with one more question here. A 34-year-old man presents with the decreased visual acuity in both the eyes. He has had many episodes of pain and redness that last for several days. His father has the same condition. His right eye is shown in the figure. Which of the following statement is true? It's a long question. Basically, the opacities are at the level of stroma. You need to find a true statement. The lesions are among the most common to recur after PKP. This condition is not progressive. Recurrent erosions are rare. You need to tell us the correct option in this dystrophy. And your time is up. So the maximum marks is given, percentage is by B. And yes, it is correct, B. So what we are dealing here is the Rees-Buckler dystrophy. This is the classical ASOCT picture of Rees-Buckler dystrophy. Nowadays, we don't do a full thickness penetrating keratoplasty. We either do DALK or anterior-lamellar keratoplasty for these lesions. But it is known to be very notorious lesion, and it comes back in whatever type of a graft you put. So they do not go to the level of stroma. And the lesion basically they are progressive, and recurrent erosion is something that a Rees-Buckler dystrophy patient is worried about constantly. So that I will stop sharing the screen, and I will again hand over the platform to Dr. Rohit for next set of 10 questions. Dr. Rohit.
Great going by both of you. Very nice.
Yeah. Thanks, Dr. Sumit. I really enjoyed the discussion part as well. Thanks. So I'll start with the 21st question from now. Yeah. Is my slide visible? Sorry.
Yeah.
Yes.
Yeah, I'll start. So, which one of the following features will most likely help to differentiate Duane from a sixth cranial nerve palsy? Concomitant esodiation, anomalous head posture, limited adduction of the affected eye, and or limited abduction of the affected eye. It's one of the favorite questions of the examiners, or in theory and practical as well. Well, the time is up, and it's the limited adduction of the affected eye. Now, basically in Duane syndrome, we get this misfiring of the eye muscles that causes the affected extraocular muscles to contract when they are expected to relax. And these patients may have limited or sometimes absent ability to abduct the affected eye and have the limited ability to adduct. That's why limited adduction of the affected eye is the right answer. Now, moving on to the next question. A 60-year-old patient came with the onset of complete painless left proptosis since 1 week. This has improved, but now the patient has diplopia with complete limitation of adduction, elevation, and depression in the left eye. Which one of the following tests is most appropriate to include in evaluation? Is it serum acetylcholine receptor antibodies, or it is serum anti-neutrophil cycloplasmic antibodies, or it is serum HbA1c, or thyroid function test? We have 5 seconds to go. 4, 3, 2, 1. So I see a tie between A and C, but the correct answer is serum glycosylated hemoglobin. The reason is that most of the patients who have painless pupil sparing third nerve palsy, they have a microvascular occlusion, which is usually seen in uncontrolled diabetic patients. Patients who have aneurysm may have pain and pupillary involvement. Now, a toddler with a recent onset develops a sixth nerve palsy, sixth nerve cranial nerve palsy. What is the most appropriate diagnostic procedure? Systemic autoimmune workup, reassurance and observation, diagnostic trial of oral acetazolamide, and neuroimaging. Well, it's sixth nerve cranial palsy. Well, the time is up. The answer is neuroimaging. Now, neuroimaging is required to rule out intracranial lesion because the child has a sixth nerve palsy associated with swollen optic nerves. Even in absence of papilloedema, acquired non-traumatic isolated sixth nerve palsy in children can be a presenting sign of intracranial neoplasm, either because of a direct local effect of the tumor, that is a glioma, or a non-specific manifestation of increased intracranial pressure. Hence, neuroimaging is the answer. When considering a diagnosis of pseudotumor cerebri, treatment by one of the following antibiotics may be relevant. So which of the antibiotics can result in pseudotumor cerebri? Whether it is tetracycline, gentamicin, ciprofloxacin, or fluconazole? So the time is up. Most of you have got it correct. That is tetracycline. Gentamicin, if injected intravitreally, is known to cause macular ischemia, whereas it is not known to cause pseudotumor cerebri. And ciprofloxacin and fluconazole again are not known to cause pseudotumor cerebri. The next question. So, a patient presents with optic atrophy. 30-year-old woman presents with bilateral optic atrophy, deafness, cataract. Which of the following should be evaluated for? Is it multiple sclerosis or pseudotumor cerebri or neurofibromatosis 2 or Joubert syndrome? So the answer is neurofibromatosis 2. Moving on to the next question. Which of the following muscles are least likely to be paralyzed by a retrobulbar anesthetic delivered within the muscle cone, whether it is a medial rectus or the lateral rectus or the inferior oblique or the superior oblique? This is sometimes which we clinically observe that even after giving a good block, we do sometimes get some movements. So the time is up. The answer is superior oblique. A 42-year-old obese adult onset diabetic patient complains of blurred vision at a distance. He inquires about LASIK surgery, and he has not previously worn eyeglasses or contact lenses, and his sugar levels are not controlled, which are in the range of 270 to 350 milligrams per deciliter, and his glycosylated hemoglobin was 8.5 last week. He refracts to 20/15 in each eye with a myopia of 0.25 sphere in the right and -2 in the left eye. Ophthalmic logical evaluation otherwise is normal. Which is the following best option for this patient? Distance eyeglass correction. Do we go for a refractive surgery? Ask him to wear contact lenses or advise better sugar control and schedule a repeat refraction? Well, it is advising better glucose control and scheduling a repeat refraction, as these patients who have uncontrolled diabetes can have visual blurring from induced refractive shifts, and that's why the preferred option is to ask the patient to go for a better sugar control. And it is possible that the patient may be emetropic and doesn't require any refractive surgery or glasses. An air traffic controller with a 4 diopter of myopia and 1 diopter of accommodative amplitude, if she uses half of her accommodative reserve, what power lenses needs to be given to her? Whether it is 3 diopter sphere or 2.75 or 3.5 or minus 3.25. So the answer is minus 3.25. Progressive outer retinal necrosis is characterized by which one of the following attributes? May occur in healthy individuals, occurs in severely immunocompromised patients, occurs with early HIV infection, occurs rarely in both eyes. A typical question which is to be considered is how to differentiate progressive outer retinal necrosis versus acute retinal necrosis. Well, the answer is it occurs in severely immunocompromised individuals. Usually patients with PON have very little vitritis, and it is mostly the posterior, or the central fundus which is involved early, as compared to OARN, which is, can be seen in healthy individuals. There is more of peripheral involvement with severe vitritis. So, which of the following lesions is most likely to be associated with complete posterior vitreous detachment? And one is macular epiretinal membrane, impending idiopathic macular hole, that is stage 1, vitreomacular traction syndrome, or diabetic traction macular detachment. We have 5 seconds to go. Well, the right answer is macular epiretinal membrane. If you look at the other 3 options, such as vitreomacular traction or stage 1 impending macular hole, in all these cases, there is incomplete PVD with a macular traction. Hence, a complete PVD is more likely to be seen in patients with macular epiretinal membrane. Thank you. Over to you, Dr. Sumit.
Thank you, Rohit. So we are all set for the last 10 questions. Sai sir, any way that we know who is leading in the chat, or it is not possible to compute right now?
Not possible right now, doctor.
Fine. So we'll move ahead with the last 10 questions. Just a second.
Very nicely framed up, but all the questions and all answers also very well given. Great going.
So let's begin. Thank you, sir. Let's begin with our last 10 questions. So again, we'll changing the gears from squint to retina to oculoplasty in oncology here. So which statement about the orbital septum is false? It's a long question. I'll be reading options a bit quickly. During entropion repair, it is very important to recognize orbital septum of the lower eyelid as it's being different from the aponeurosis of the lower eyelid retractus. The orbital septum arises from a condensation of periosteum of the orbital rim called as the arcus marginalis. The orbital septum inserts on the superior border of tarsus in upper eyelid, and the orbital septum serves as a barrier to the spread of infection from superficial eyelid to the orbital tissue. And that ended up your time by the time I finished. Okay, so 51% say it's C, and yes, they are correct. So here the orbital septum gets attached to the aponeurosis of the LPS instead of the tarsus of the upper eyelid. That was a little change made there. During the entropion repair, you need to open orbital septum to go and actually hold the eyelid retractor to do entropion repair. Yeah, it is called as arcus marginalis, and the orbital septum serves as a barrier to spread the infection, which is very common, and that's why we get more cases of preseptal cellulitis than orbital cellulitis unless it's a penetrating injury, because we do have our septum to prevent the infections from spreading anterior to posterior. So moving on to the question number 32. Which gland does not contribute to the aqueous layer of the tear film? Option A, gland of Cross. B, main lacrimal gland. Option C, gland of Zeiss. Option D, gland of Wolfram. A simple question, but what I'm asking here about is aqueous layer of the tear film and not the whole and soul tear film. So read the question properly. Last 5 seconds. I expect 100% to get correct here. Let's see. Poll is locked, and yeah, a little less. It's 72%. It's gland of Zeiss. The gland of Cross, Wolfram are accessory lacrimal glands, and the main lacrimal gland are basically responsible for the aqueous layer of a tear film. The mucin is secreted by the goblet cells of the conjunctiva, and mebum basically comes from your mebumin gland, the oily layer. So here the option C is the correct option. Moving on to question number 33. In patients with ptosis, 2.5% phenylephrine hydrochloride test does what? May activate the sympathetic receptor in the molars muscle, resulting in the elevation of eyelid. Option B can be used as a to assess the approximate elevation of the eyelid with the external levator advancement. Option C, it dilates the pupil so that the contralateral eyelid may drop. Option D, does not affect the blood pressure through the systemic absorption of the phenylephrine. So this is the test we do in cases of ptosis, generally a mild ptosis. This is basically to decide the plan of management further. The last question was answered correctly by 72%, but this question is answered correctly by 82%. So correct, it activates sympathetic receptors of the molars muscle and basically that's a correct. It does change your blood pressure by the systemic absorption, and you might have to do a punctal occlusion. It's very less concentration, so it will not cause will not see the contralateral eye droop. And again, it is not the indicator that we use during the surgery for the levator advancement. So correct, and it will not act on the levator. It's basically a sympathetic simulator here. Moving on to question number 34. Adult patient presenting with epiphora with a complete obstruction at the sac duct junction. It's a sac duct junction. Would expect to have option A, negative dye disappearances, positive Jones 3. Option B, positive dye disappearance, positive Jones 1. Option C, positive dye disappearances, negative Jones 1. Option D, negative dye disappearance and the negative Jones 2. So these are two test results that I am talking about. If you see even a one correctly, you will be able to answer it very well. Don't get confused because I have written results of two tests and not the one. It's an adult patient presenting with epiphora with obstruction. Poll locked, and yeah, so most of you have given answer D. As I said, that please don't get confused. The option correct is C here. See, the dye disappearance test is going to be positive. Any amount of block, let it be anywhere on the lacrimal sac or the canalicular system you have. So it has to be a positive dye disappearances. It will not be negative. Because how do we interpret dye disappearances that the fluorescence stays in the conjunctival cul-de-sac? It's a positive test. So if there is a canalicular block or there is a NLDO block, then you are going to always have a positive dye disappearance test. So that's why you need to concentrate only on the option B and C here, not on the A and D, which is D is marked most commonly. Now the negative Jones 1, of course, negative Jones 1 is basically you don't get any staining of the bud when you keep it in the nostril because there is a block. So the negative Jones 1 is good enough to diagnose what are you dealing with and where is the blockage. So option C is correct and not the option D here. So everyone tried correctly but got confused because the two test results were given and not one. Moving on to the next question. It's an interesting one. Question number 35. 11-year-old girl presents with the acute unilateral left-sided periocular pain, proptosis, and double vision. 24 hours later, and without any treatment, the pain has resolved. Periocular ecchymosis has developed, and the double vision is stabilized. The MRI results are also available, which are shown in the picture. the most likely diagnosis on the clinical history and the MRI finding is? So good, now you got the options. It's option A, rhabdomyosarcoma, option B, capillary hemangioma, option C, orbital abscess, option D, lymphangioma. So you properly see this is a 11-year-old girl, and there are very, very, very less conditions which present as an acute unilateral proptosis. So among the very few ocular emergencies, out of that very few orbital emergencies, this is one of the emergencies. Poll is logged, and again there is a tie between B and D, and the quizmaster says option D is correct for a simple reason that if you see here, anytime, suppose even if you don't have the MRI, you don't have a clinical picture, someone is telling you history that a young adolescent girl or a boy presents with the acute proptosis, you need to think of a diagnosis of a lymphangioma. Capillary hemangioma is not so common at this age. It's basically a capillary hemangioma of infancy. Lymphangioma, on the other hand, will classically present with the proptosis and the ecchymosis, because lymphangioma everyone can have, and if it spontaneously or post-trauma bleeds, then you can have a sudden proptosis which will not be there in any of the condition, including the orbital abscess. Orbital abscess will be more related to the pain and it will not disappear on its own. Rhabdomyosarcoma, of course, can present in this age, but it will not be so acute and it will not resolve on its own. So what are we dealing here with the lymphangioma, and how do you treat? It's basically either surgery, or nowadays we do give a sclerosants intralesional orbital injections of PC-banil or bleomycin, which are very good treatment for this. So one of the orbital emergency, a rupture of lymphangioma. Let's move on to the next question. What is the most common cause of unilateral childhood exophthalmos? And your options are capillary hemangioma, thyroid related orbitopathy, orbital hemorrhage, orbital cellulitis. So what, please look after the every word in the question. It's the most common, unilateral, and childhood proptosis. Capillary hemangioma, thyroid, hemorrhage, or cellulitis. This is the tricky one, but the easy one if you read the question properly. And I hope everyone gets it correct. So 61% of you got it correct, not bad. Orbital cellulitis is most common. Capillary hemangioma, if asked, most common benign lesion of childhood capillary hemangioma, agreed. But it will not always cause exophthalmos, because orbital capillary hemangioma, as we discussed, are rare. If the question would have been adult exophthalmos, thyroid related orbitopathy was correct. If the question was traumatic exophthalmos, orbital hemorrhage was more correct. But since this is asked only about a most common cause, then the orbital cellulitis. So all are correct answers. Only thing is question need to be a little differently framed for that. So question number 37 here. You can see a picture, histopathological. Sorry for a black and white one, but it was more better seen this way, so I put it. A histopathological slide of orbital tumor is best treated by option A, exenteration and the removal of the involved bone, option B, radiation, option C, chemotherapy, and option D, all of the above. I can just give a hint that what are you looking at is basically a lacrimal gland tissue with large tubular elongated cells, abnormal in a lobular pattern, giving you a cystic adenoid appearance, and that ends up your time. Still, I hope everyone diagnosed it correctly, because everyone has answered correctly. 54% of you answered all of the above, because what are we looking at is basically adenoid cystic carcinoma, most common malignant tumor and most aggressive one of the lacrimal gland. Okay, and it does present with the tubule solidness or sometimes a switches pattern, and which is an indicator of what you are looking at is a very aggressive lesion. And it need a multimodal management of chemotherapy, surgical excision, sometimes exenteration, and of course radiation also. Moving on to the third last question. In congenital nasolacrimal system obstruction, where is the level of obstruction? common canaliculus, lacrimal sac, wall of Rosenmuller, wall of Hasner? Very simple question. It has to be there out of 40. And again, I expect at least 100% to answer correctly. Congenital LLDO, which we know how do we treat, most of the cases till the age of 1 year, we just advise them massage because we expect the dash obstruction to open. I cannot answer, 5 seconds are still there. And if it does not, then the 12 to 18 months is a very good time period in which you can actually do a probing and treat the disease. And we are waiting for the poll results. Meanwhile, I think I can go to the answer. It's wall of Hasner, basically. And it is a cause of epiphora in most of the newborn infants, which we treat with the massage and the topical antibiotic. And 90% of them do respond to the conservative therapy. And just to a bit of anatomy, wall of Rosenmuller, basically, it's there to prevent the reflux bit from the lacrimal sac again to the your conjunctival cul-de-sac fit between a common canaliculus and the lacrimal sac. And what are we talking here about was basically a wall of Hasner, which is at the NLD. So I think the poll is still getting answered. We'll move on to the next question.
Doctor, just hold on for a minute. 1 minute.
Okay, I will hold. Last two questions.
Very nice explanation, Sumit. Very well done. And in fact, they are convinced about whatever is you are selecting as the answer is the right answer after the explanation. Otherwise, certain questions, it is all absolutely clinical, one by one. The way Rohit also mentioned regarding the diabetes, HB1AC, it really clicked. Baba, this is the right answer.
Yes.
So very well, nicely organized. Well, I was not party to any of the answers, so I am the audience also participating.
Otherwise, you would have won, sir. So yeah, I think 72% have answered correctly. Okay, we'll go with that. Good. And I am happy that no one marked lacrimal sac as an answer. Very good. So let's move on to the next. I said I can move on to the next question, correct?
Yes, yes.
So second last question here. Concerning the thyroid related orbitopathy, the most common recommended surgical order of therapy is option A, decompression followed by strabismus followed by eyelid retraction. Option B, eyelid retraction first, then decompression and then the strabismus surgery. Option C, decompression and then the retraction. Option D, retraction, then strabismus and then the decompression. No, I just changed the question format. You do see an inactive thyroid eye disease patient presenting with the scleral show and not happy with their cosmetic look, and 76% have answered A, which is the correct answer. Of course, you do orbital decompression. After that, you do strabismus because if it is involving the vertical muscles, then you need to bring patient at least to a approximate orthophoria before you do a lid retraction, because your measurements do change, and after that eyelid. So it goes with the simple way of orbit first, then eye muscles and the eyelid. You logically it goes posterior to anterior if at all you want to remember in a logical fashion. Now coming to the last question, xanthosma eyelid lesions have all the following features except. So you need to mark which is not a feature of xanthosma. Option A, associated with the systemic hyperlipidemic conditions in approximately 25% of the patient. It's located in the basal epithelial layer of the skin. Option C, associated with the Erdem-Chester disease. Option D, microscopically contains foamy histiocytes. Xanthosma, very commonly seen lesion, and we do always investigate them. Generally, though, they are present in the elderly, but if they are present in the younger population, we need to be more and more careful about xanthosma. So 52% have answered it as a B, and correct, it is B. Basically, it's present in the dermis and not in the epithelial layer of the skin. And of course, it is associated with the hyperlipidemias. And as I said, if it is in the young, then you need to be very careful. You need to see for telltale sign that are you dealing with something called as a hyperlipidemia of familial hyperlipidemia, or are you dealing with xanthogranulomas, which could have a systemic implications in the patients, and you need to investigate even a simple case of xanthosma according to the age and the size of the xanthosma presenting to you. And I think that ends my 40 questions here. I'll stop sharing my screen, and we will give some time to our technical team to compute the results.
As he computes the result, I would like to introduce Dr. Sumit Lahani, which I had forgotten. So sorry about it, because you introduced Rohit. He is one of the most dynamic, the associate professor at the JJI hospital, and he is also working and very active in conducting all the quiz. One quiz that has been conducted by Dr. Bhavan Kore for years together. He is always part of it. He is there to organize. He is very ready to help, and a very human at heart and very humble. Whenever I ask him anything, he is always ready to be there to help me. So also is Rohit. Rohit is the past secretary of the Bombay Ophthalmological Society, and also a veterinary surgeon par excellence. He is also always there to help us. So thanks both of you. You have done a wonderful work. The way you have conducted it, and also convince the audience with the answers why this has been chosen. And it's a big learning for everybody, including me. I have learned a lot of things during this quiz also, as I had participated. Without knowing any of the answers, I have also tried to see how it works out. And a big thank you once again. And Sai, for all the technical support that you have given. Anything you'd like to add, both of you? The way I think one or two things we need to change is for the long questions we need to start it after we complete it. That is what is one in one question only it happened that day you finished and the time was up. I think majority we did cover it. So I think that next time we'll rectify that too. Yeah, over to you, Sumit and Rohit, both of you, and of course then Rajesh Joshi also for the vote of thanks later.
Sir, just wanted to, appreciate the mega initiatives which have been taken by you and your team for
Yes.
all the MOS members. They are absolutely amazing. Financial literacy, the health awareness, and the journal club. I can just go on, and you are so kind to involve everyone. I believe any person who has even shown a slightest interest is a part of one of the initiatives. And another thing I would just like to add about Sumit's nature, which I've known for many years since my internship days, is he's so humble and down to earth.
Yes.
And every time I call him for some guidance or help, he says, "हाँ sir जी, आप बोलिए हो जाएगा." So, I really
Other way around,
appreciate that
Rohit.
humbleness.
The feelings are same. We are mutual, and I know it. When I ask anything to Rohit, the no will never come. The no is not there in the options. And thank you, Jignesh sir, for involving us and considering us. It's very nice and kind of you, because both of us like to get involved in such academic activities. And when you pair us and then you give us opportunity, it's basically a cherry on the top kind of a thing for us. So really, thank you. We got opportunity to again to work together.
We have the results with us now.
I suppose yes, sir.
Yeah. Who is going to announce it? I think you announce it. Sumit, दो तुम announce करो, दो रोहित को करना है. That will be better because you paid
Let's
all the
do
pain.
that.
And the person now, I just would like to say before it declares the results, those who have already participated in the first quiz and won the prizes won't be eligible this time. I think Prasob has already won that last time. So the next 4 we'll have to take. But anyway, thanks Prashant for being part of this quiz and winning again, once again. Yeah. Sumit.
Yeah. Here I can see only 5. Number 2 is Dr. Niranjan Karthik Senthil Kumar, who has answered 31 questions correctly, and within 13 minutes he stands second. And number 3 is Prabhat Vinay Nangia. He is answered 29 questions in 9 minutes and he stands third here. Rohit, can you announce 4th and 5th, please?
Yeah. So the Dr. Anupama Jain has come forth.
got correctly 29 out of 40, but the time was more. I think so that's why she is fourth. And Dr. Rahul Lokhande has answered 24 out of the 40, and he stands fifth.
So now here I would say is the first winner of the quiz will start with Niranjan. Prashop, of course, a big congratulations. Again, you have won it. But as you have already won in the first quiz, let's give chance to the rest of the four which we have declared. We are going to give four prizes. Directly, it will be coming through the Microvision people. We are extremely thankful to the Microvision people for sponsoring all the prizes. All the four prizes are lovely prizes. You'll be getting it there at your clinic and in your this thing, because we have your registered mobile number and the name. So they'll be calling you and handing it over the prize to you in person within the next 15 days. So thanks a lot, each one of you, for participating. And the second and the third prize, I'll just explain you. We are taken is the response time. Fastest fingers first. So a person who's on the second has taken 9 seconds to answer it on an average, where Anupama has taken 10.36. And that is why instead of having a tiebreaker, we are having the second prize as Prabhat. So big thank you once more. All of you for participating. Last time we had about only 30-35 people. This time we have doubled up the numbers. Hopefully next time more people will join and take the benefit. It's a learning curve also. Plus you enjoy the quiz. And thanks once again to Sumit and Rohit for wonderfully conducting the quiz. The way they had jotted down and structured the quiz, it was very enjoyable. Totally different from what we had conducted, me and Shilpi, on the first round. And thanks, Sai, for the wonderful backup that you give and the technical support, and for the games. And the Endowed people, you would like to show you a quick video, corporate video, before Dr. Rajesh Joshi sums up. And Rohit and Sumit to give the
Sir,
concluding.
Microvision.
Yeah.
It is Microvision.
So this is
Microvision, yeah.
Amit sir, do you want to play? You can go ahead with the
Corporate video. Quick.
Yeah.
Yes, sir.
Yes, one remark, concluding remark from both of you, and then Rajesh.
So I would just like to conclude by saying thanks, and thanks for all the participants. Since you are there, you are showing enthusiastic response. That's why the program, and you show more and more response. I am sure that Jignesh sir will keep coming with better and better models, and Microvision with better and better prizes for
Right.
all of you.
That is important.
Over to you, Rohit.
Rohit.
Yeah, thank you. And I would also like to thank Sai. It is really wonderful to work with him because he is always available 24/7. So thank you, Jignesh sir, Rajesh sir, Sumit, Sai, and Microvision. Thank you very much.
Yeah, Sai sir stayed awake till 2 o'clock yesterday just to put these questions in order.
Yeah, and he has
I
changed the
think
gears.
he works
Very
round
fast.
the clock for these programs to happen, and he's the man behind it. So thank you, Sai
Absolutely.
sir.
Absolutely. In last first quiz, what we had was a totally different platform. Now this time he changed the gears so fast, and seen to that it seamlessly ran the whole show. Very nice.
Thank you.
Rajesh, over to
Yeah,
you.
I congratulate all the winners and all the participants. Thank you, Dr. Sumit and Rohit, for conducting it so well and making it so interesting. And of course, Microvision for the prizes and providing the platform, and Sai for all the technical support. And thank you so much. Till we will meet next month.
Yes, it's a monthly quiz, so please do join. Those who have not won the prizes are again eligible to play and to win the prizes. Those who have already won can play but cannot claim the prize. Thank you very much.
Thank you.
Thank you, everyone.
Bye and take care. Chalo, all. Sai, especially you. Good job, yeah. Last minute
Thank you,
hiccups were
Ashok sir.
there.
Thank you, Microvision. Thank you, Sai. Thank you, Rohit.
Thank you, doctor. Thank
Amit
you very much.
bhai, bye bye.
Thank you, sir.
हाँ,
Thank you.
हम माइक्रोविजन से हैं सर.
हाँ, बिल्कुल. माइक्रोविजन से ही मालूम है, वो गलती से बोलते बोलते हो गया. एनीवे.
ठीक है सर.
विष्णु भी है ना?
हाँ है
आप
सर.
भी है. और अशोक कुमार साहब ज्वाइन हुए थे कि नहीं हुए आज? Because there is a huge list. I did not see.
नहीं सर,
Join,
he is traveling.
ओके, थैंक्स. उनको थैंक्स बोल देना. और ये प्राइजेस
sir.
का जो है नाम नंबर ले लिया आपने, तो उनको नाम भी पता है अभी. See that it is conveyed, and I have told you, take a photograph and take a message, congratulatory
Sure, sir.
message from them.
Sure.
Okay, चल.
Yeah.
Chalo,
Thank you.
bye.
thank you sir.
Thank you.
I think Sai, me and Rajesh will stay for about 2 minutes before everybody can rest. Log off, please. Thank you for joining. Yeah, Sai.
Yes, Dr. 1 minute. I'm just stopping the recording.
Yeah. This will